We are now going to go to one of our videos with Dr. Matulonis, who's going to present a patient case.
Good afternoon, everyone. I'm Neil Love from Research to Practice, and to make this CME meeting more relevant and practical, I met separately with three noted clinical investigators: Professor Jonathan Lederman from the UCL Cancer Institute in London, United Kingdom, Dr. Ursula Matulonis from the Dana-Farber Cancer Institute in Boston, and Dr. Angela Secord from the Duke Cancer Institute in Durham, North Carolina, to brainstorm about clinical scenarios and related research data sets in advanced endometrial cancer to present to the faculty for their input. To begin, Dr. Matulonis presented an older woman with de novo metastatic mismatch repair-proficient metastatic endometrioid endometrial cancer treated in the pre-immunotherapy days.
She's 78 and 5 years ago developed postmenopausal bleeding. An endometrial biopsy was consistent with a high-grade endometrial cancer. She also had noticed perhaps some mild shortness of breath. She's a very, very active lady. And the doc taking care of her at that time point did a chest, abdomen, pelvic CT scan showing innumerable bilateral lung nodules, right lung biopsy consistent with a high-grade endometrial primary. She did undergo a laparoscopic vaginal hysterectomy with a BSO. Path showed a grade 3 endometrioid cancer measuring 6 centimeters in largest diameter, and also pretty deeply invasive into the myometrium at 80%. Her NGS showed a TMB of 11. She was MMRP. She went on to receive 6 cycles of carboplatin and paclitaxel. This was before, obviously, the more general use of potentially adding an immunotherapy drug to carboplatin and paclitaxel. So pretty remarkably, she's had a near CR. 5 years later, she is now without evidence of cancer and doing well and really thriving. The question to the panel, would you have added pembrolizumab or dostarlimab to carboplatin and paclitaxel?
We all see cases like this. Dr. Powell, I'm going to start with you. So what are your thoughts on this case, and what would you do if you had this patient today?
Yeah, so these are tricky cases, and this one, obviously, somewhat the exception, did well. I will review a little bit about GOG 209, where carboplatin paclitaxel by itself doesn't do very well. This group with her biomarker assessment with P53 mutation seems to be a group where immunotherapy may be helpful. Now, again, we don't have all the data in yet. And it's really frustrating. GY018, we probably won't have our translational science looking at the molecular subgroups till the end of the year. But I think we would certainly have a strong discussion about adding immunotherapy into this patient.
Yeah, and Dr. Backus, this patient was ER negative, which we know can be associated with a poor prognosis. What are your thoughts on this case, and what do you do when you see an ER negative case specifically?
I think for me, has two things, like ER negative and also grade 3, and we know that those are going to be less likely to respond to less likely to respond to hormonal therapy. So I would not have used that. Before now, yes, with immunotherapy available, definitely would have done that. In this patient before, may have even considered adding bevacizumab or something like that in this P53 mutated patient. But she did well without and didn't have to go on maintenance. So this definitely, we have to sort out. If we only could know.
Yeah, I think these are always challenging cases. Knowing today, I probably would have added immunotherapy with this advanced stage 4 patient, but the patient did remarkably well. So patients with advanced endometrial cancer, we are looking at multiple different biomarkers. You mentioned P53. We didn't really talk too much about BRCA and HRRs we don't really, use it so much in clinical practice, but you did mention it in context of trials, and then you did talk about HER2 status. So how important is it for you to biopsy a metastatic or recurrent site versus using the primary tumor? Or do you oftentimes test both, looking for any differences in tumors? I'll start with you, Dr. Backus.
So I think it is important because we know that these tumors, especially, that they can evolve over time. We can see responses in one part, and we can have something else that is persistent and that may be treated differently also. We have so many more options now. Repeating, I guess, in a lot of situations, like if the patient was HER2 positive, I probably wouldn't repeat. But if she was negative, yes, I definitely think that repeating a biopsy can be helpful to have another option for treating these patients in the future also.
Dr. Powell, anything to add?
No, I would agree. I think, up front, I don't think I would have biopsied the metastatic site, if it wasn't going to change my management, as you just said. But at relapse, I probably would be considering it. Certainly, we can see more HER2 as the tumor advances. And if I have a target and it's already there, I probably won't retest. But if it's not there, I'll look for it.
Yeah, I agree. And there's in the breast cancer world, they'll often retest for HER2 status multiple times until it kind of declares itself. So I think we're learning more about endometrial cancer, but it's a very exciting area. I'm curious, you mentioned ctDNA, and I think it's such an emerging topic and such an important thing. I'm curious if you're using it in your practice today. Dr. Bacchus?
I struggle with it a little bit. I don't know if I'm making any friends with that, but it's hard. So I've had patients ask about it. So in those cases, I use it. The hard part is, what does it mean? Like if my patient is on a treatment and now she's ctDNA negative and it turns positive, I still don't really know if I need to treat her now or if that means that in 2 or 3 years from now I may need to start treatment. So I'm a little hesitant to sometimes to get that information because I don't really know if it's just helping me or helping the patient or causing more anxiety. It's nice to have that information available. It's more to maybe to de-escalate that it may help us than actually to say, when should we escalate?
Yeah, Dr. Powell, anything to add?
No, the only thing, hopefully we'll have some evidence from your GYO2O study for the earlier stage patients. Knowing whether we need 1, 2, 3 years of therapy would be great to know that, but it wasn't embedded and tested in our trials. But hopefully, as we learn more about those tumors that express circulating tumor, we can learn going forward. But I think it's a few years before I can recommend that for routine practice.
I agree, and it's interesting because I think that you mentioned de-escalation of treatment. I think that's kind of a very enticing opportunity to use ctDNA. But we do have, this direct-to-consumer marketing, and so patients are often asking about it. And I think it's a little problematic because we're probably seeing some lead time bias if we're, using it for treatments. That's what we're probably seeing in some of these studies. I think it's a really interesting emerging area, but I think it's still, to be interpreted with caution. And we may be over-treating patients or treating them earlier than they really need. So next question I have for you guys is, are you conducting molecular analysis for all of your patients with endometrial cancer, early stage, late stage, or are you being selective in your approach? Matt?
No, we certainly do it for all. I mean, it may not all get polymerase epsilon testing, but in the cases where it would matter, especially clinical trial eligibility or some de-escalation approach, we will do it there. But understanding what their risk for Lynch syndrome and other issues still are important. We actually look at HER2 for everybody, just for what you showed with the HER2 in the serous population. Those that were positive have much worse outcome, and obviously to target them for directed trials like GYO26.
Dr. Bacchus, are you doing poly testing universally? Or are you reserving it for select cases?
We just had another discussion with our pathologist. Pathology group is kind of where maybe other people are struggling too. We cannot do poly in-house, which is very difficult. So we do have to send all of these out and we don't have an in-house large molecular panel. At least there's a small one. But if you're going to test and you're going to pay the price, then we would have to send it out, or we do send it out for NGS testing with just one of the available companies.
And I apologize if I missed it. You do that for which patients?
We're working towards a strategy to do it for all, but I don't know. Do you guys do it for 1A grade 1?
No, not typically. And if they met higher risk criteria and we were targeting for the GYO32 trial, then we would. But again, they kind of have to be higher risk. For the 1A ones, we're not doing that at this point.
There are some clinical pathologic features that you may find. So some of these like more aggressive looking tumors, but earlier stage. And our pathologists are so keen. They'll be like, hey, you may want to test this for POLE. We can do it in-house, but we do it selectively. And I think that's been kind of informative. So hopefully we'll learn more as cost comes down, accessibility. So, we all work with fellows, and I know there's some in the room. What do you do when a fellow asks you, what are the long-term outcomes with checkpoint inhibitor therapy? I think DMMR is pretty settled, but how do you explain to them with the PMMR population? Dr. Powell, what do you tell your fellows if they ask you this question?
Well, I was going to say for the DMMR, I'm actually presenting tomorrow our 4-year follow-up data on the RUBY trial, which does allow us to give an estimate if they make it to a year or longer, what their risks of long-term survival. I'm not going to give it away. Previews. But I'm going to stick to the question. So PMMR, clearly, there are long-term survivors in that group, and it's certainly less. And as we put the whole molecular formula together, what their HER2 status is, what, obviously P53, the type of mutation may matter. We launched a trial looking at the addition of bevacizumab to the pembrolizumab and carboplatin paclitaxel because we think there may be a role in our P53 mutated patients, especially those that have what's called a gain-of-function mutation, may be best served with the addition of bevacizumab to that backbone. So much like our 4-drug regimen in cervical cancer.
Mm-hmm. I'm going to close out. I'm just going to say, I think it's a challenge. I think their chemotherapy is clearly not enough. And I think the role for a maintenance strategy is probably really important in these patients with advanced diseases.